Hi, everyone. We'll get started here. First off, I'd like to welcome you all. Thank you so much for coming. My name is Monica McGrath. I'm with a company called HLS Therapeutics. We're here partnered today with Saladex Biomedical to bring you this industry workshop. And it's my pleasure to introduce Dr. Vincent de Geer. So I'm just going to read from the bio here. Dr. Vincent de Geer is a clinical biochemist in the Optilab Montreal CHUM Laboratory Network, associated researcher at Maisonneuve-Rosemont Hospital, and a clinical assistant professor at the University of Montreal. He is the chair of the working group on laboratory errors and patient safety of the International Federation of Clinical Chemistry in Laboratory Medicine, and acts as an expert on the working group of the pre-analytical phase of the European Federation of Laboratory Medicine. Dr. de Geer is notably the president of the Canadian Program for Quality Indicators Comparison of the Quebec Society of Clinical Biology and a chair of the Committee on the Quality Improvement through Quality Indicators Monitoring of the Canadian Society of Clinical Chemists. Highly involved in the technology development and advising in laboratory medicine, he is a co-founder of Anisons and LabMed Alliance. Thank you, everyone. And the talk today will be on the therapeutic drug monitoring in psychiatry, the positive impact on patients through lab clinician collaboration. Thank you.
Thank you so much. I'm so glad to be with you guys. I mean, what an extraordinary venue. I would like to thank the organizers for having me and HLS and Saladex. So please don't panic if I fall on the ground. I did a really big hike yesterday afternoon and the legs are a little bit shaky, but I'll try to manage this for the full hour. So nice combination of nice venue and for me, like a very passionate and important project we've been doing in the last years in Maisonneuve-Rosemont Hospital with TDM, of course, for psychiatric patients and measurement of clozapine. So my goal is to share some key information about how we were able to make the difference for patients with TDM, the importance of collaboration between the lab and physician when it comes to these types of project. We're going to talk about turnaround time because for me, it's super key in this project to be able to really make the difference for patient, providing timely results when it matters. And if we talk about TDM, we talk about, yes, speed of results, turnaround time. We also talk about quality of results and accuracy. So we will cover this as well. I just want to mention that I receive speaker fees from HLS, but all the content that I'm providing in my talk is based on the literature and the validation we've been doing in Maisonneuve-Rosemont lab. So this is a team project. I'm the only one here. I'm the only lucky one to be able to present like the first time in my life in front of the mountains like this. But this is a teamwork. And there was a huge synergy for that project between the lab and physician. And I'll go over that point in my presentation and a little bit the dynamics and the timing of things to be able to build up this project and convince everybody it was worth it. So a lot of collaboration with the clinicians, the psychiatrist, the pharmacist in my hospital network. The Montreal Health Institute is a main center in Quebec, a lot of activities there. So nice work between the clinicians, but also the lab team, a lot of work in the lab for the assay validation and all the organization of the project. So yeah. Definitely a teamwork here. So it all started with a discussion with the clinicians about a huge problem they had with their patient in psychiatry, trying to treat patient on clozapine, but having quite slow turnaround time. And I'll explain why turnaround time were so long. Basically, this analysis was considered like a super specialized analysis that was centralized in one center, right? So the center was doing a great job, but with all the send out and all the process, turnaround time were actually like 9 to 12 days easily between blood sampling and results. So they were saying that it was not quite possible for them to do like safe follow-up for their patient, considering the potential of critical values and the need and the plus value of doing TDM with their patients. So we built up the case and we were able to showcase this to let's say the administrative side to be able to convince them that it was worth it to jump in this project. But first, like 3 years ago, my background and experience with the clozapine was pretty much when I was on call, and then the lab was calling me, and they were telling me on Friday afternoon at 4 o'clock, we have a critical value for clozapine. We're not able to reach out to the physician. And then I was asking, okay, when was the blood sampling done? And then it was like 10, 12 days ago. And I was like, how come we're communicating critical values, like so many days afterwards? So before the physician reached out to me, like I was already wondering, like, how comes turnaround time are so long in a setup where it seems to be important to provide quick results for patients? So as we built the case, we reviewed with the physician, and I think this is very important because when you're building your case, you want to be able to provide information on the plus value for our patients, right? This is true for the administrative side, but this is also true for the lab side. We're all like extremely busy. Staff shortage is the reality in all the laboratories, I would say, across the world. So why should we prioritize this project over all the other things we need to do in our labs? So actually, they made a super clear and relevant list of where it could make the difference for their patients. So they were talking, and I'll go really fast on this because we will look at this in detail, but they were talking, of course, and you'll see it's really like a TDM setup there. So during titration of clozapine, if there was insufficient or non-existing response, to look quickly at the concentration if there was an adverse effect. In the onset of smoking for these patients, you'll see there's a huge impact. Drug interaction as well. The inflammatory syndromes, we'll talk about this, super challenging with like super high value of clozapine. And also try to figure out when the patient is showing up and he's not really stable, is he taking his medication? And if he stopped, like how many days ago? And of course, at the ER, in the case of an intoxication where we need to move rapidly. So for me, like the case was done. I saw the value of moving forward with this project, and I really wanted to provide a better service to clinicians. So, like we have some medical specialties where they have like high volume of lab tests, right? Nephrologists, hematologists, like there's like a close relationship with the laboratory. Psychiatrists, they're not necessarily like the high demand physician on lab tests compared to other specialties. So it was super important for me to, like understand better what was the need. And also after looking at the story with the turnaround time and like the value I exposed in my last slide, I was like, I shouldn't tell you this, guys, but you're not complaining enough. You've been running like this for the last 20 years. Doesn't make sense at all. It's fine if you take the phone sometime and, like just fake you're pissed off and talk to me. You need something, right? So, of course, like we're talking about like very vulnerable, that was a tough one for a French guy, but like very fragile patient where it's quite important to have a tight follow-up and have extra tools to be able to follow their condition. So, like this patient will face hallucination, they're gonna be disorganized behavior as well, impaired cognitive ability. So you can imagine the challenge of follow these patients, trying to figure out when's the last time they took their dose, they took their medication adequately. Furthermore, if you look at the rate of mortality for this patient, unfortunately, it's 2.8 times greater than the, I would say, normal population. Unfortunately, because of suicide, but also for all the other conditions that they're struggling to manage when they are disorganized. So you can see the value here of making sure that these patients are staying in the stable and the safe zone. So actually, there's different treatments when it comes to schizophrenia, and actually, clozapine is ranked quite high when you look at the capacity of this medication to avoid, for example, in that case, rehospitalization. So there was a drugs that, like had good potential, but unfortunately, like if we're talking in terms of TDM, I don't think it was possible to do like a good follow-up of these drugs. And it was actually limiting the use of the medication as well. And this is exactly, so what we did, we built the case, like the clinical teams did an amazing job of building these documents, providing all the different points, the table I presented earlier, but also a lot of other important points, such as the fact that we're all aware about the fact that there's like important drugs and meds to follow tightly. So nobody would argue of having, like the importance of having fast turnaround time for lithium or valproic acid or tacrolimus, right? So clozapine, it's in this type of drugs we need to measure, but actually it was the only one where we had such long turnaround time. If you look at the literature, it's quite convincing. And this is a very nice paper. And I found out that it was published by my colleague, pharmacist at the Mental Health Institute, super clever guy, super involved in the research on clozapine. And so actually they were able to rank different drugs based on the criteria of what's the value for this drug of being able to do adequate and efficient TDM. What is very surprising, and it's a little bit small, but if you look at clozapine, you end up with a score of 15 compared to lithium with a score of 12. So can you imagine this? Basically, it would be more even important to be able like efficient TDM for clozapine more than lithium. Then look at the turnaround time. This is turnaround time for lithium, like few hours. Lithium is there. Clozapine was there. Okay, so definitely there was a problem. So, and furthermore, there's clear guidance on what should be the target for clozapine measurement doing TDM. And this is not a new paper, right? It's even before COVID. Can you imagine how long? It's 2017. So it's super clear. You should at least provide your results within 48 hours, but you should try to aim for 24 hours. And for some cases, for example, for intoxication cases at the emergency room, you should be able to provide results within hours. So it was not the case at all in our previous setup. So why it was so long? Actually, the reference site running the HPLC, because it was run on the HPLC, it's still run right now for the other network in Quebec province. So they were running it on HPLC. They were doing quite a good job considering it was like what we call a supra analysis, so very specialized analysis, centralized in one center. They were doing like 3 batches of clozapine per week, but with all the process of receiving our samples in my hospital in HMR, and unpacking and putting this in the freezer for like a send out once a week, sending the sample, receiving the sample, unpacking, put it in the freezer as well, doing the analysis, sending back the results. Then I need to enter the results in my LIS. It's a never-ending process. This is why it was taking so long. So the idea was to be able to shorter that process significantly. So what's the setup for the lithium, valproic acid? It's on our chemistry analyzers, right? You put it on your analyzers right away. So that was the idea with the MyCare assay that we were able to implement and validate on our Atelica instruments in the lab. We have 4 chemistry instruments connected to our automated track. So we were able to load the sample on the track and results was available like within minutes, right? So this is a big change at the level of delivery for turnaround time and organization for the lab as well. It's less complicated for us to load the track than doing all the process for send out, right? So it's an immunoassay, immunoturbidimetric, and you also have other antipsychotic drugs available, but we will focus on clozapine. So we were able to launch the immunoassay in November 2022, and actually we provided guidance to or physicians on the difference at the level of the assay, and we wanted to make sure that they were aware of the change. So implementing the immunoassay, we were able to decrease significantly turnaround time. So you see this is before and this is now. And so we're able to provide turnaround time of few hours from blood sampling, no matter where it's coming from in my hospital network. So huge difference and huge improvement for TDM of these patients. So actually, my hospital is part of a laboratory network in Montreal, and we have all these different sites. So we're running the immunoassay in HMR, but my partner sites are also sending their clozapine to HMR. So as you can see, and turnaround time for some of these guys were even worse with like 2-3 weeks before. So we were able to improve significantly turnaround time, not only for our hospital, but also for the other hospital that were part of our network and are sending sample more frequently. As physicians, we're able to have like full value of clozapine results with TDM in a timely manner. Look at the increase of volume we were able to see right in the first year in 2023. So what you see here is, but there's a lot of activities in my network with psychiatric patients. So we already had like good volume of clozapine. We were sending out about 2,200 clozapine per year. We had an instant increase of 50% the first year we implemented the test because physicians were following their patient more tightly, controlling the results as well. We'll talk about this a little bit more. And this is actually like the volume we have for all my laboratory network. Interesting observation. It's only an observation, right? But if you look at turnaround time and like the value of having these results within few hours, if you look at the volume of the test, it's mainly like almost 80% of the requests are from the physician from my hospital and around with the mental health institute. So it's only like 22% for the other sites. However, I think turnaround time improved, but it's still over 48 hours for some of these sites. So I'm wondering, right, do we have kind of a correlation between test requests and the capacity of having these results as fast as possible? So we were able to assess the plus value for patients to be able to provide results within hours. And this was a good work done once again in collaboration with the physician. And we were able to publish a short article in TDM giving clear example how we made the difference for patients, providing results within few hours. So I'll go through these examples with you guys. So basically, first thing, to be able to manage non-adherence. And that was a key point mentioned by the physician. A patient is showing up, he's disorganized. What's the reason, right? Is it because he's not taking his medication? So what's the value of doing the blood sampling and then receiving the results 2 weeks later? It's not working. So that was a case of a male smoker. You'll see that even there's a challenge with smoking, especially when these patients are getting in the hospital and needs to stop. So he admitted discontinuation of clozapine for 96 hours. It was usually around 1,200 nanomole per liters. So we were able to provide fast results of clozapine. The pharmacist was able to realize it was 300 nanomole per liter. So he was able to do some blood sampling, calculate the half-life, and have a clear strategy on how he should treat the patient to restart the clozapine. So usually with these patients, if you're doing it blindly, you need to restart from scratch. And then you will keep these patients at the hospital for 7 to 13 days. So do you see the value for these patients to be able to keep them at home, just knowing exactly what's going on and having a clear plan on how they should restart and getting in the green zone for their stability as fast as possible. And you can also imagine all the impact for these patients to get in the hospital as well. That was actually a point from the psychiatrist when we built the case about the fact that having a tool to detect non-compliance could drastically reduce rehospitalization for these patients. So that was a clear example that it was the case. And the rate of utilization of clozapine for these patients is quite high in my network. It's 17%. It's quite lower for other sites. But physicians were also mentioning that if they could follow up adequately doing TDM, this rate of use of clozapine could even increase, considering the benefit for patients to use this treatment, but if they can have tight follow-up of the drug. The other case was about the tolerance of supratherapeutic range in case of infection, and we'll talk about the inflammatory syndrome more in detail later. But you will see, and I will explain why you will have super high concentration of clozapine in the context of inflammation, and even critical values for these patients. What's challenging actually is you won't necessarily find sign of toxicity even if you have critical value. I'll explain why. So that was a way also to, yes, have a fast results, identify as well that the patient had an inflammatory process, but monitoring the patient more tightly. So they will do clozapine every 24 hours or every 48 hours at the beginning of characterization to be able to make sure that clozapine will reduce and they are in the safe spot. The effect of inflammation is super big for clozapine concentration. And this is a case in the literature, but I'll show you some clear example we had as well. So as you can see here in orange, it's doses of the medication of clozapine. You see here, it's quite stable. Nothing is changing, right? Clozapine concentration is right over there. And look at this huge increase, 3 times. This is what you can see in the inflammation process. 3 times increase of clozapine concentration. Of course, it's critical. So how can you manage this situation if you're receiving the result weeks later? And as you can see, depending on the situation, it can also decrease quite fast. So you see, they were able to manage the patient, adapting the dose of clozapine based on the inflammatory process going on and the concentration of clozapine that were provided. So this is exactly what they're doing. So establishing half-life of clozapine, especially in the inflammatory context, it's kind of personalized medicine, right? So do you really want to use like the standard protocol that if the patient has a critical value, then you stop medication? And I'm not a psychiatrist, so I won't go into details, but you know, like stop medication and to make sure, you know, like there's not adverse effect for patient to have critical value. So this is personalized medicine, adapting the dose based on concentration and status of patients. So management of constipation as well. So actually, clozapine can induce constipation. Constipation will increase concentration of clozapine. If the transit reduce, you will have more absorption of clozapine, and you will end up having significant increase of clozapine concentration. So this is a case where they actually realize, as I mentioned, you know, like it's not necessarily easy to have feedback from these patients, some of these patients. So they actually realized the patient was constipated because he had like super high critical results of clozapine. And so they were able to treat the patient, and clozapine normalize really rapidly for the patient. So other situation is to be able to assess the minimal effective dose, management of clozapine-related adverse reaction, management of smoking. We will talk about this. And so it's to be able to act on results. So metabolism of clozapine is a bit tricky, but it's like all the different drugs. But there's different and many factors that can have like big impact on clozapine concentration. So it's metabolized by specific cytochromes. So as soon as you have, for example, competition with the same cytochromes with another drugs, or you have situation where the activity will change, then you will have an instant impact on clozapine concentration. So this is the case with smoking. Actually, smoking will speed up the metabolism for these patients. This is a huge problem for patients that are hospitalized. Hospitalized? Yeah. Hospitalized. I know. Yeah, I have. Yeah, I have my own way of. Yeah. I prefer my way. It's more like French, French style. I'll try to remember, but I can't promise. So, and I won't say it again. So when they get in the hospital and they need to stop smoking, you will have an increase in clozapine concentration, actually. Okay, and it's quite complex. It also depends of what type of smoking you're doing, and it's like life is quite complex with smoking right now. You have different tools, so this is tricky for management. So with this paper, I think we were able to showcase the value of having fast turnaround time for clozapine to manage our patient. And we were super pleased to have a paper published in TDM by the psychiatrist and pharmacist of Mayo Clinic, not too bad, endorsing our work. And I love the first sentence. We applaud Vincent et al. Advocacy for clozapine therapeutic drug monitoring. It's amazing, huh? I showed this to my mom. Actually, it's not me. It's Philippe Vincent that was the first author of the paper, but still, I like to fake that they're mentioning me directly in the paper. So finally, if we're talking about TDM, we're talking about turnaround time, but we're also talking about accuracy and specificity of the assay, right? And you will see the process in the implementation of clozapine. For me, it was an amazing project just only because I really felt we made the difference for patients. But it was like the school of life of what strategy you should take implementing a new test. And it was not my first new test, but I'll go with you through our history of implementation regarding specificity, accuracy, and assay validation. So we're moving on the new assay. I started to have like significant number of calls from physicians, saying, I have a critical value. How do I manage an unexpected critical value for my patient? Are you sure your method is accurate? Okay. Actually, what we realized is that a lot of physicians were asking for clozapine, but we're not using the results much because timing was not there, right? So for example, and we'll talk about all the different results because I will assure you that the assay is accurate and specific, and I'll show you all the verification and validation we did. But we talked about smoking, we talked about inflammation. There's a lot of situations where you will have a spike of concentration without necessarily sign of toxicity. So if you have this situation and the physician received the critical values 2 weeks later, he'll just say, oh, okay, we're not there anymore. Like blood sampling was 2 weeks ago. If I call them 2 hours, 3 hours after blood sampling, they need to manage this. So that was an amazing example here about, for example, the physicians, I think it was at the emergency room, that asked the pharmacist to have kind of a short class on how to manage critical values of clozapine. They've been asking clozapine for the last 20 years, but it's like if it was the first time, really, they could act on results. So about the accuracy of the assay. So I was quite impressed and pleased by the validation that was done by Saladax. And I'm not saying there because they're here right now beside the mountains, but like that was a package insert clinical biochemist friendly. It's the type of package inserts you want to have with like standard CLSI assay validation with a lot of information. So all the parameters were already validated, and they were providing information about repeatability, precision, linearity, everything you need to know, right? And performance was quite good. Of course, we validated the assay ourselves. So super good precision and repeatability on the assay. And what you see here is compared to the literature, there's a very nice paper published by Clark and Hall that were the first to publish data on validation of the MyCare assay. So we had similar results for precision. I'll go fast on this, but we also had like good results for sensitivity, 188 nanomole per liters. It's like all good enough to monitor the patient. We were able to validate the linearity as well. I'll talk about this a little bit more later, but good linear range for measurement of clozapine and correlation. So we were actually the first one in Canada implementing the immunoassay on the chemistry instruments. We were actually the first one in the world implementing on the Atelica instruments. So we were able to do really like deep validation to really well characterize the assay. So we did a correlation with like the method of reference. So the Saladax assay on the Beckman instruments, that was quite good. And we also did the correlation with the HPLC that was doing the measurement in the province. Actually, you can see that if you're looking at the overall BAs, it's like if there's no much impact. However, look at the distribution of the differences for the different samples in the correlation. There was important difference for some samples between methodology. And we'll talk about this a little bit later, about the challenge of the dynamic of me providing fast results of clozapine and also having some physician that wanted the ratio of norclozapine and clozapine and ending up having two clozapine results on the same report. Nightmare. Nightmare. So we were able also to classify based on the reference range. It was all good. And so beside all these assay validation that were like quite good and we were super confident. So I still received some calls saying, like I have critical values. I still have unexpected critical values of clozapine. Actually, HPLC is lower. If the patient doesn't have any sign of toxicity, you would like to pick the lower results, right? Over the higher results. So some of them were asking again, are you sure your immunoassay is accurate? So we bonified our correlation with over 120 different patients with the HPLC. And we saw actually, we're all aware about the fact that results are method dependent, right? I'm telling you, it's not clear for physician, not at all. Most physicians don't understand that point. And most physicians take results for cash. The idea also of precision, imprecision of the assay and everything, it's challenging. So it's super important to be efficient communicating these aspects to physician and tell them, hey, you cannot follow your patient with a mix of immunoassay and HPLC. And actually doing all these verification, we really think that there was underestimation of clozapine concentration on the HPLC. But still, we did thorough validation of the immunoassay and actually discussing with the physician, I showed them, hey, if you look in the literature, so this is results from Clark and al. Showing that actually their immunoassay are significantly lower than the LC-MSMS. So don't think that it's necessarily, like the overall picture that the immunoassay is higher than chromatography. So to prove our point, we did some accuracy experiments, so spiking with expected clozapine value and looking at the rate of recuperation. So it was quite good with our target of plus minus 15%. So we were super glad to see that, it was accurate on actually a quite range of concentration. And we'll talk about this a little bit later, but my assay is supposed to be linear up to 4,359 nanomole per liters. But as you can see, it's quite good even if you go higher. Look also, so this is triplicates. Look also about the precision of the assay. So, like sometimes you could say like, oh, unexpected high value. Is this a problem of precision? It was not. Precision was super tight as well. If you're looking at the AQA program for the CAP, so this is our results for 2023. So you have our results here in red, and then you have like the peer group for the immunoassay in blue, and the peer group for LC-MSMS in green. Once again, if you look at the trends, LC-MSMS chromatography overall is higher than the immunoassay. So this is the message I tried to push to my physician, saying, I understand that you see differences between our methodology and the old one. They were used to it. They've been using it for the last 20 years. So also, like their responsiveness and the way they were interpreting the results was really based by the old method. But the message was like, yes, maybe I release higher results. I'm telling you, I'm accurate. And if you look overall, it's not standard that the immunoassay is higher than the chromatography. We also looked at a lot of different experiments at the specificity level. So quite specific. Saladax looked at a lot of different compounds. I'll show you some tables as well. But basically, norclozapine, we'll talk about this, of course, and other metabolites of clozapine. Slight increase for quetiapine, but still quite low with an increase of 5%. So it's negligible. So super specific. This is the list of compounds that you can find in the package inserts. All these compounds were tested and no problem of specificity with all these different compounds. So I was like, good job, a lot of efforts. Now, you know, like they will understand my point. We don't have any issues with accuracy of the immunoassay. Hey, hi. Glad it's accurate, but I still have unexpected critical values of clozapine. Are you sure your method is accurate? I was not close of the burnout, but I was like, yeah, this is challenging, right? So this is where we started digging, and that was like the super value of working super tightly with the pharmacist and the psychiatrist of the Mental Health Institute that add like the clinical side of the results, right? So we started digging. I need to mention Philippe Vincent, pharmacist. Yeah, the Vincent in the maillot, the real Vincent. That was super good analyzing the situation and, you know, like trying to identify, I would say, reasons why we would have these observations. So we actually realized, looking at the difference between HPLC results and the immunoassay, we realized that most of these patients had an inflammatory syndrome going on. And actually, and you know, like inflammatory syndrome overall, there's a lot of different reasons, right? And we launched our immunological assay in COVID. So you can imagine that inflammatory syndrome was like very present. So first of all, the release of cytokines can inhibit the cytochromes that will metabolize, will actually decrease metabolism of clozapine. So you will have a raise in clozapine results. Secondly, and this is very important, clozapine is bound 95% to AGP, alpha-1 glycoprotein. AGP can increase up to 50% in inflammation. And this is a very important point. So you can see an increase of total clozapine, but do you think it will necessarily transfer to an increase in the free form? That, by the way, is the form that is active. So actually, that was interesting experiments. We were looking at the literature, and actually, you know, like this paper was spiking AGP at different concentration, and you can really see a decrease in the free form concentration of clozapine. And this is not necessarily related to the inflammatory syndrome. I'm sure there's some patient that had inflammatory syndrome, but if you do kind of a correlation between the concentration of AGP, normal versus elevated, you don't see much difference, or you will see an increase with the total fraction of clozapine, but you will actually see a decrease of concentration of the free form. So that explains why you will end up having like critical values, and I'll show you some concentration range, super high concentration of clozapine without having any sign of toxicity. And I think I read in the literature that it can go up to almost 60% of cases where you're going to have high critical values of clozapine without sign of toxicity related to this. And this was one of the examples, right, that we showcase to be able to tightly monitor clozapine concentration to at least understand the trends when we manage these patients. So we started to dig a little bit more with the inflammatory syndrome. And actually, I was able to do extraction, and we looked at results of clozapine where we also add a CRP concentration, right? And actually, we said, okay, CRP greater than 5, good odds of inflammatory syndrome, less than 5, no inflammatory syndrome. So, and that was quite a good set of samples. I don't remember the exact number, but I think we have like a couple hundreds of sample there. Oops, sorry. So as you can see, look at the median concentration of these patients. No inflammatory syndrome compared to inflammatory syndrome. It's quite higher, right? So we're going from 1,000 to over 1,500, 1,600 nanomole per liters. I'm a Quebec guy, I'm in nanomole per liters, right? Apologies. And look at how high it can go. So I think, you know, like that was the point there. Inflammatory syndrome, overall, you will have increase of clozapine concentration. If you take the group with critical values, 95% of patients with critical values also had an inflammatory syndrome. So that was the confirmation of the cases where high concentration of clozapine, no sign of toxicity. Once again, it's not a matter of accuracy of the assay. The assay is accurate. It's the matter of total clozapine versus free clozapine. And so we were able to see like super interesting trendings. So these graph actually, I apologize, it's a real pale, but I really wanted to have the view as I was presenting. So in blue, you have concentration of clozapine on the immunoassay. In gray, you will have concentration of clozapine on the HPLC. And in yellow, you will have norclozapine, of course, on the HPLC. And so doing all these measurements, and you know, like we had an overall rate of immunoassay versus HPLC of 85% of requests on the immunoassay and 15% on the HPLC to have the clozapine-norclozapine ratio. We'll talk about this more in details, but what I want to say is we had a lot of data where we could compare both methodology. And look at this, I love this case. Concentration of clozapine normal, 1,800 nanomole per liters. And then look at this. This is a case of red phone, right? Hey, what the hell? Why do you throwing me a critical value? My patient, you know, like I didn't change anything, right? This is the same thing that the literature didn't change anything. And now you're throwing me a critical result. But look, CRP, super positive, inflammatory syndrome. Same thing for the other one. This is like more the baseline for this patient. Inflammatory syndrome, quite high. Same thing, spike in clozapine concentration. So you really need to communicate this information to your physicians. They won't necessarily be aware of the impact in the inflammatory syndrome. Just to show you how deep we went. So this is a study done by Saladax looking at the impact of increase of AGP with the immunoassay. So we wanted to make sure as well that, you know, like going through the inflammatory syndrome, it was not something related to the inflammatory syndrome that we're increasing the concentration of clozapine. We know it's not the case, right? But still, so they spiked increased concentration of AGP, representing even 3 times what you can find in the inflammatory syndrome. You don't see any interference or change of results with clozapine with an increase of AGP. We also did a correlation with total protein, Maybe, you know, like in the inflammatory process, you still have like increase of inflammatory protein. It doesn't necessarily show up in total protein, but still did the correlation. No correlation at all between clozapine concentration and total protein. So as you can see, you know, like it's quite specific and accurate. Still, hello again. Glad it's accurate, and thanks for the info for the inflammatory syndrome. But concentration for these patients are super high. Are you sure your method is accurate? This is not staged. That was the process. Yes, concentration are super high in the inflammatory syndrome. And I was so happy to find this paper where it was a systematic review of over 40 different studies of case of patients going through inflammatory syndrome in different contexts, and they were providing actually concentration of clozapine. So if you plot this, this is based on the table. Look at the range of clozapine concentration. This is huge, right? Going up. So the 75th percentile, I'm at 8,000 nanomole per liters. So yes, in the inflammatory syndrome, you can have super high concentration of clozapine. And this is a mix of studies. So this is a mix of labs that are using different methodology for detecting, mainly chromatography. So it's important as well to be able to provide feedback for physicians when it comes to super high concentration of clozapine. So actually the good thing is when we did our accuracy experiment with the spiking of, you know, like broad range of concentration of clozapine, we realized that even if the top linearity of the assay is at 4,359 nanomole per liters, we were able to go higher, and the instruments was providing actually concentration, and accuracy was quite good, even up to 7,000 nanomole per liters. So we're looking at these options right now as we did the validation to be able to provide kind of an estimated concentration of clozapine for the physician when they receive greater than. They get really frustrated when they receive greater than, and I understand, because they don't have any tool to monitor the patient knowing. So this is a real case. I think she was 66, but that's not important. But the woman showing up at the emergency room, okay, suspicion of intoxication of clozapine. So we provided greater than 4,359. They were interacting. I forgot to change it, but in English, it's the poison control center. There you go. There you go. So the poison control center really asked for an estimation of concentration because they wanted to see the trends. What's going on with the patient? Is it still increasing? Is it decreasing and things are going under control? So actually we were able to provide. We told them, hey, it's like truly validated up to 4,300, but we can provide estimation of concentration, and they were able to see that there was a trend where concentration was decreasing and getting back to normal. For this patient, 4-5 measurement of clozapine in like 36-48 hours. So you see here the value of providing results within hours in the case of intoxication. So, hello again, and thanks for the info for the inflammatory syndrome and explanation for high concentration. But should I request a norclozapine-clozapine ratio because you don't provide it? So that's a fact. With the immunoassay, and I showed you, it's super specific. The clozapine assay won't detect norclozapine concentration. And yes, there's some requests where physicians are asking for the ratio of norclozapine-clozapine. Why? Because they consider it will provide information about the metabolism of clozapine by patient. So this is like, I would say, the difference between chromatography versus immunoassay. However, as I mentioned, the rate of request for the ratio is already quite low in my network. And this is a super good review that was published, doing a systematic review of all the papers looking at the value of the norclozapine-clozapine ratio. And actually, the conclusion are the following. They did not find that the ratio provided information on responders versus non-responders. They didn't see nothing supporting the idea that the ratio was providing information on the cytochrome activity. And also, there were no significant difference between smokers and non-smokers. As you recall, you will have a change in metabolism as well. And there were no difference between male and female regarding the clozapine ratio. So I think we see this in the rate of request as well right now with physicians. So we're still in the process of having the formal approbation for the immunoassay. So I'm still providing also the possibility to have I'm not limiting the request on HPLC right now to physician, and I have 85% of request with the HPLC measurement. So I think it's going to get lower, even lower, when we move forward officially with the immunoassay. So finally, hello again. Do you want a coffee? I want. Good. So amazing project. I hope I was able to showcase the value of collaboration. That was my favorite part. Super proactive, synergic collaboration between the lab and the physicians. I was able to reach out to them anytime. There was like some clozapine champion, right? They were not the ones struggling with for example, the critical results. But I had instant access to them to be able to troubleshoot, to be able to set up what was the next step for validation and this type of things, good strategies for communication for their colleagues. They were inviting me to their medical meetings so I can provide more information on the assay. I also hope you really saw the value, and I think that the necessity of having fast turnaround time of clozapine for these populations that are very fragile, and I think deserve to be able to have like efficient TDM having their medication. And finally, all the work that we've been doing on the accuracy of the assay. Conclusion, the immunoassay is accurate, it's specific. However, you need to be aware, and your physicians needs to be aware of all the reasons where you will have, for example, super high concentration without necessarily sign of toxicity. As I mentioned, it's a teamwork. So a huge thanks to all the collaborators. I would like to thank you for your attention as well. And if you have any questions, I'll be able to take the question. Thank you. Do we have any questions? Yeah.
Fantastic presentation. Thank you.
Thank you.
I was wondering, how long did it take them, now that they were getting results within 3 hours and they actually had to do something about it, how long did it take them to come up with workflows to address the critical value in real time?
That's a good question. And, you know, like, I think it was fast, but maybe not fast enough, you know, like if we had like clear path of how do you manage this, the challenge is that we receive sample from so many different sites. So, you know, like we have, we're providing lab services in the east of Montreal to 500,000 patients. So there's a lot of different sites. It was more straightforward with some key partners with like big teams of pharmacists and psychiatrists. In other cases, it was more challenging as well with psychiatrists of other sites, other laboratories that were sending out results. So I would say some key sites organized quite fast. Others, it took a little bit long time where they were, like wondering about the results. But I think they still needed to organize quite fast because the critical results were, like kept getting in. So my point was that it's not legitimate for me to provide information on how they should handle their patients for critical
Absolutely.
values, right?
Absolutely.
But I
agree.
was trying to bring as much as information as possible regarding results, like the inflammation and this type of things, so they can get around this and organize. The emergency room with the pharmacist, that was quite fast because then they were like, oh, okay, how do I need to handle this? How do I handle it?
Got it. And the reason I asked is because we had a similar situation where we had to decide whether we wanted to bring in Keppra, anti-epileptic, by immunoassay or by mass spec. And we ended up going with mass spec because the emergency room said, we don't know how to interpret Keppra levels. And the neurologist rarely responds in time. So,
Yeah, that's crazy, right? Doesn't make sense. So, yeah.
so now they have like a 24-hour turnaround time instead of.
So you see, like this is where it's important you have like key champions on the lab side, but also on the physician side to be able to provide the information, right? Doesn't make sense at all that you don't know how to handle this. This is something we've been talking a lot also to try to provide guidance on how you should handle these results. Once again, it was not possible for me to, I could collaborate on this, but it was not like legit to me to bring the way they should handle their patients with critical values.
Yeah, and we felt the same. Like if the ED and neurology did not have a good partnership, I couldn't do anything about it.
Yeah.
Right.
So of course you can bring like literature or use cases from other centers. This is why as well we were super happy to publish the short paper. It's quite short and straightforward, but it really gives like clear example of the value. Like having also kind of a, like how should you handle these values. So for like the sites that were really used to the clozapine, it was super clear for them. So Philippe Vincent knew exactly how to deal a critical result in any type of situation. We had trouble also, like there's some situation where we were calling the critical values within hours, in the night, in the weekend. A physician on call was taking the critical value, was not super aware of how many, like he was supposed to manage this situation. And not in a lot, but in some cases, they stopped the medication and then, like impact was even worse than. So right. It's super important to be able to provide clear explanation. I think we have a part of the responsibility, but I think physician needs to take their part as well to be able to organize and make things right.
Thank you.
Thank you, Vincent. Very good presentation, very complete. I have a question that's related, not directly to this topic, but I'm hoping that because of your relationship with the psychiatrist, you might be able to answer. We know that that mental illness and drug addiction are very closely linked.
Yeah.
As I understand it, we're not always sure whether it's the mental addiction that leads to or the mental problem that leads to addiction, or the addiction that leads to the mental problem. But I'm wondering, in this case, to me, it would be a good example, another good reason to be able to provide this drug and this care to these patients, for fear that if they don't get the treatment they need, they will self-medicate.
Absolutely.
They will end up addicted. Is this what you're finding from the physicians as well?
Absolutely. So it's all the impact of not being able to be in the safe zone for these patients. So we can talk about drugs, but we can also talk about, for example, like some of these patients have heart failure. They need to take their medication properly. If they are disorganized, they won't treat themselves the right way, right? So the impact is super big and super broad. As soon as they get disorganized, then you will have like multiple levels of impact. So this is why, I mean, I think it's, I felt it was my responsibility to be able to provide any tool possible so they can, you know, like really manage these patients as good as possible.
Okay. Thanks again. Good to see you again.
Thank you.
Thank you very much. So, and it might be an unfair question for you because
good.
you're not the, you're not the one treating the patients. But if your level goes high in inflammatory processes, right? But the free doesn't really go high.
Yeah.
So do you know what the psychiatrists are doing? Because presumably you don't want to be decreased in your clozapine.
Exactly.
Because your free is okay. And if you decrease it, the inflammatory process resolves and now you're too low. So do you know what they're doing?
Yeah, so this is where I think they will go with signs and symptoms. And that was one of the example where, you know, like Philippe Vincent was talking about to be able to tolerate high concentration of clozapine and not necessarily changing treatment. Because if you change it, then yes, your total concentration will reduce, but the active form will reduce as well. So then you can have your patient not having optimal concentration. So I think it's tricky for them to really know like what's the best strategy. And I think it's also depends of their level of comfort of managing these situations in the settings of the psychiatrist and the pharmacist in the mental health institute. I felt that it was super clear for them that it was not because they were receiving critical results that they were automatically changing things. So what they were doing was following the condition of the patient with the inflammatory process, keep following the clozapine concentration. And Philippe Vincent mentioned me once that they want to wait also sometimes a little bit so inflammatory syndromes goes to see what's the actual concentration of clozapine. So it's not black and white, but I think the key thing here is to be aware that it's not because it's critical in the inflammatory syndrome that you have impact. Of course, unfortunately, there's other cases that you really have toxicity. A related point to this, following the discussion with the clinicians, we decided to change also the comments regarding critical values. When we report critical values, mentioning that, you know, like and it's the case, some patients tolerate really high concentration of clozapine, and this is the doses that works for them. So it's really patient related as well.
It kind of makes me wonder if we should actually be measuring free.
I was mentioning the same thing.
Yeah.
I was mentioning this yesterday.
Yeah, it makes you wonder. Yeah, I mean, obviously there's reasons why we do free phenitins, and I think there's lots of interest in free valproates. And
you know, like in the cases where we had like the inflammatory syndrome and battling a little bit with saying, no, it's accurate, right? I was like, I wish I had like the free form just to show them, yes, your total is critical, but look at your free form. You know, it's in the standard range. However, the problem is, what's the standard range for the free form? There's not much stuff
that's another project
available.
Can I, sorry, I know people might have to go to their next session. So I don't know if anybody else got a question, but can I see the slide on the quetiapine interference?
So this is the only one we had a slight increase, but it was not considered, you know, like as significant with like the around 5% and even less at higher concentration of clozapine.
Okay. it was a little light, so I just.
My fault. My fault.
Okay, thank you very much.
My pleasure.
Oh, sorry, got one more question. Did you, because people, when they're used to getting something like their norclozapine levels, you know, they're very attached to those.
I know.
Did you say that 85% of your clozapines are still being done by HPLC? What did
The
I?
opposite.
Oh, okay.
15%.
Oh, okay.
And we got lower, but then with like the specificity thing, and we had a slight increase. The problem is like, I need to have like the formal approval to, you know, like to be able to say management of clozapine is with the immunoassay. If they want the ratio, fine. And I had a good discussion with Giorgio. His family name is a little bit challenging, and it's recording right now. But you know, like there's some, like Quebec is like an environment where like the ratio, physicians, you know, they ask it more than other places around the world. I think there was a lot of studies done on the ratio, but there's not much. They can be like specific cases with specific drugs that could battle with the cytochrome, but it's a super small number of cases. So I really think that the rate of request will decrease. And I think I would actually provide, you want the ratio? I'll provide the ratio. I won't provide the clozapine concentration. It's a mess having different concentration for the same patient. So at some point I said, okay, if you want the ratio and you want the HPLC, I'm sorry, but do another blood sampling. I don't want to provide two different concentration of clozapine on two different methodology on the same report.
Yeah, I was going to say, you might just say you get one or the other. You have to choose
Exactly.
fast or the ratio.
So this is basically where we're going. We just need to have like the formal approval before doing so. Yeah.
All right. Well, thank you.
My pleasure. Thank you very much. Yeah, sure.
I think we need to recognize that calling of the critical results for clozapine, it's a very, very tricky matter. As a matter of fact, at Center for Addiction and Mental Health in Toronto, a group of lead psychiatrists really didn't want the lab to call the critical results. So when I came on board, this was the situation. They said, don't bother us because of the reasons we discussed. And in the CAMH patient population, of a good number tolerate levels up to very high,
super high,
even up 8,000 nanomole per liter. But from a laboratory perspective, I think this is a liability. Like for as long as we have guidelines that identify, like the guidelines that you mentioned, identify critical, well, they call it alert, but okay, I think it's a liability for the lab not to call the critical results.
Maybe this is where, you know, like, is it like a flag or is it critical or is it another?
I know, that's what I'm saying, it's tricky. So I have implemented the call because of the liability of the labs. They were not happy, but nothing we can do about. However, it's how when you suspect inflammation, do you reflex to CRP or
That's
are you
where I would like to go. Good call.
Are you going to?
I told them,
yeah,
if you have an unexpected increase, ask for CRP as well.
Or maybe we can reflex it for CRP.
Exactly.
I don't know, but this is an ongoing friction, if you will, because you call, they say, oh, I know, I don't know, you know, kind of.
So what we decided to do, so we will change our policy of, so like the official path of critical value is you have 1 hour to call, right? So we decided to move on to 24 hours. It's not implemented yet, but this is where we would like to go. A window of 24 hours to call to at least make sure we are able to talk to the physician that is in charge of the patient instead of the team on call. Because The main problem with communication is about the fact that you communicate the results to a physician on call that don't necessarily know the
I
patient.
know, yeah. Or we put an, I'm working now on putting on interpretive comment,
Yeah.
as you said, that they don't need to change the dose if they don't think it's necessary.
So at some point,
that's for
I
them.
thought that we were moving on removing calling with clozapine. That's what the psychiatrist mentioned me in a meeting. But then when it was the time to take the formal decision, they changed their mind.
Yeah.
So I agree. I think it's the same thing as you mentioned. If it's somewhere in the guidelines saying that 3,100 nanomole per liter is toxic.
So either we work towards changing something in the guidelines or losing, because I have to tell you, when it comes and bites us, if you will, if we don't call the critical results when there are cases with huge impact, sometimes death. And then the next question, and the patient is on clozapine, and the next question, guess what the next question is? What was the level of clozapine? I didn't know it was so high. I mean, yeah, that's what I'm saying.
That's a challenging
it's
part.
a challenging topic, and we still have work to do.
So, and I think it's quite difficult to do some rational about should it be like calling for the emergency room and not for outpatients.
I know. So it's quite a bit of project, and
I think it's a very important point.
In the field of psychiatry and clozapine. Did you report the ratio as such, or you let them do the calculation? Are you reporting the ratio?
I think we report the ratio as well.
That was a curiosity question. Yeah. Okay. Thank you very much.
My pleasure.